So the study accrued and enrolled a total of 128 patients with inhibitors, without inhibitors, who had hemophilia A or hemophilia B. They needed to be in the age range of 12 years to less than 75 years of age, and they needed to be at least a minimum of 35 kilograms in weight. Of course, without inhibitor. And just to make sure that, in fact, the drug had the maximum effect, we needed to identify those individuals that could maximally benefit. And the way we did that is, if they came in and they were on demand treatment, they needed to have at least 6 bleeds in the preceding 6 months prior to enrollment. And if they came in from routine prophylaxis, they needed to be at least having 80% compliance on their current factor 8 or factor 9 regimen in the previous 6 months. We excluded, of course, individuals who had a history of coronary artery disease or arterial thrombosis or ischemic heart disease. We also excluded those who had planned surgery, those who had platelet count of less than 100,000 or a hemoglobin of less than 10 grams per deciliter, and anyone else who was receiving immunomodulatory therapy, as well as those who were participating in gene therapy or any other non-factor therapy were excluded, and they were not included in the study. And in fact, for those 128 individuals with hemophilia A or B without inhibitors, they needed to go through a 6-month observation period, during which we were collecting data on their baseline bleed rate. Of course, during that period, we ensured that the bleed rates were collected, and also their treatment was also collected. And then, following the 6 months, the individuals were then invited into a 12-month active treatment period. In the active treatment period, they received a single subcutaneous loading dose of Marstacimab of 300 milligrams, followed by the weekly subcutaneous 150 milligrams. The 12-month period, of course, had the option of escalating the dose of the 150 milligrams weekly to 300 if the individuals met the dose escalation criteria, and those were if they had 2 or more bleeds in a 6-month period, and they weighed at least a minimum of 50 kilograms. And at the end of the 12 months of active treatment, the individuals were then invited to participate in the open label extension, in which they continue to receive the maintenance dose of 150 milligrams every week. So the bottom line is that we were looking at the endpoints, which were the annualized bleed rate for treated bleeds. And what we observed in this particular study was that Marstacimab significantly reduced the annualized bleed rate for treated bleeds when compared to prior routine prophylaxis and prior on-demand treatment for these patients. For the reduction in those who were on prior on-demand treatment was a 92% reduction, a reduction from a mean estimated ABR of 38 to a mean estimated ABR of 3.2. When those individuals, in fact, moved on to the open label extension, the reduction in annualized bleed rate was maintained at 3.9 at a mean model-based ABR of 3.9. And similarly, if one looks at those who were on prior routine prophylaxis, we saw a reduction in annualized bleed rate of 35%, in absolute values, a mean model estimated ABR from 7.9 to 5.1. And in the extension period, there was a further reduction in the mean ABR to 2.3. So essentially, it looks like, in fact, the Marstacimab significantly reduced the bleed rates in this cohort of patients without inhibitors. One needs to perhaps contextualize the safety aspects of this particular study. When we looked at overall the adverse event rate as well as the serious adverse event rate, we're quite satisfied that, in fact, the safety profile of Marstacimab in hemophilia A and B without inhibitor was actually quite acceptable. And perhaps noteworthy from the safety perspective was the evaluation of the antibodies, the anti-drug antibodies directed against Marstacimab. What we found was that out of the 116 individuals that were tested, 23 tested positive for the anti-drug antibody. Further evaluation revealed that this anti-drug antibody had no impact whatsoever on the safety, and in fact, the in vitro further analysis revealed that 6 out of the 23 of those antibodies had at least an in vitro neutralizing effect. Even with that neutralizing effect, we did not see any change in the pharmacokinetics. We did not see any change in the bleeding phenotype. And I think it's important to contextualize the outcome of this study, that one is just not looking at the efficacy, but we're also looking at safety. At the end of this particular basis cohort, there were no thrombotic events that were observed in this particular study. I think that is very, very important, perhaps to note from the safety perspective. So the ongoing basis study ab initio, in fact, had 2 cohorts, those without inhibitors and those with inhibitors. The study that I've just described was the study for those without inhibitors. The study with inhibitors is currently ongoing and certainly should be published soon. And in fact, perhaps if I were to jump the gun, we see the similar pattern of impact of Marstacimab on the bleed rate in the patients. All of the patients that participated in these 2 cohorts were invited into the open label extension, and I've briefly mentioned some of the results of the open label extension. And the thinking here is that, in fact, that is currently ongoing, and we've observed, of course, the impact of Marstacimab on bleed rates. We are starting to analyze other secondary endpoints in this patient population, including the impact on target joints. That data is now going to be presented in the near future in a congress. We're looking at the impact on musculoskeletal in general. We're looking at the impact on quality of life in this patient cohort.